Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Tiffany Hensley McBain. Today's episode features content from an educational program titled Contemporary Management of HIV. During this podcast, Dr. Bedimo from the University of Texas Southwestern Medical Center and the VA North Texas Healthcare System in Dallas, Texas, and Dr. Daar from Harbor-UCLA Medical Center and David Geffen School of Medicine at UCLA in Los Angeles, California, discuss management of heavily treatment-experienced patients with HIV. For more information on Dr. Bedimo and Dr. Daar, and for a link to the full online educational program, including downloadable slides specific to today's discussion, please visit the show notes for this episode. Now let's get started and hear what Dr. Bedimo has to say about heavily treatment-experienced patients and assessing virologic failure.
So first of all, the scope of the problem. It remains a clinical challenge in some patients who are heavily treatment experienced and living with HIV. So antiretroviral therapy with novel mechanisms of action, can play a critical role in this, albeit smaller and smaller over time proportion of people living with HIV. Those are patients with resistance to multiple drug classes and who have no or limited treatment options. Primary targets are two, older people with HIV treated in the early days of antiretroviral therapy, not only with less potent agents, but with agents that had low resistance barriers. Also, like we can see in some case-based analysis, they often went by necessity through sequential addition of single agents that were active. And then we have younger people with congenitally acquired HIV who have now been growing into adulthood with extremely heavy exposure to antiretrovirals. Currently, we do have maravirol, ibalizumab for stemsavir and FACP as only options. Now, for stemsavir is administered orally, and I should say also is maravirol. Then we have ibalizumab and FACP that are injectable. You can see here in this cynics analysis, a cohort of 26,000 antiretroviral therapy experienced people with HIV who are receiving care in the US. The limited treatment options was defined here as 2 or fewer available drug classes with 2 or fewer active drugs per class by resistance testing. And that proportion has declined from 5 to 7 in the early 2000s to a little less than 1% now. Now, 1% of the people living with HIV in the US is still a lot of people. So it is important to come up with treatment strategies that address this heavily treatment experienced population. And who are these people likely to be? We just mentioned earlier that 2 populations to target are older individuals who went through sequential therapies with drugs with low genetic barrier and perinatally acquired HIV. And this is the second group of these groups, young adults with perinatally acquired HIV are currently transitioning to adult care. And pediatric HIV/AIDS cohort looked at among 88 participants with available viral load testing, 56% had 1 or more instances of unsuppressed viremia, which is the perfect setup for development of resistance. And this was the case in the year prior to transition, that 56% of them had 1 or more instances of unsuppressed viremia. And they were more likely in the table presented below to be Black than white or other races. And they were equally as likely to be males or females. How do we manage patients with virologic response? This is a quote from the DHHS guidelines. Assessing and managing a patient who is experiencing virologic and antiretroviral therapy is experiencing failure on antiretroviral therapy is complex. Expert advice is critical and should be sought. Yeah, and the bottom is important because adherence is in red here to say that the number 1, number 2, and number 3 reasons for in likelihood for failure is a poor adherence. And we're going to go through some scenarios looking at when adherence was not disclosed or was not even identified by the people who were not adherent, and may have led to unnecessary switches of antiretroviral therapy. So drug-drug and drug-food interactions have to be considered. So it's drug tolerability, HIV and CD4 counts over time. Antiretroviral history has to be taken into consideration whenever analyzing virologic failure, and prior and current resistance testing whenever available to you. And some with refractory treatment failure will respond to the current regimen if adherence is assured. This is another way of saying that lack of adherence, so whether it has been identified or not, has to be a primary consideration for why people are failing antiretroviral therapy. This is an 8-day inpatient directly observed therapy, antiretroviral therapy, for patients with extensive antiretroviral therapy resistance and high rates of self-reported adherence. So these are people who reportedly were very adherent and were were experiencing virologic failure and were put in an intensive 8-day inpatient directly observed therapy. 9 of 20 or 45% of them had virologic response, and 4 or 5 of those with perinatally acquired HIV had virologic response. So this is important to consider such a study to avoid unnecessary regimen changes whenever possible. And those who were more likely to have non-response to directly observed therapy were those with a median number of major and minor drug resistance mutations that were higher, an average 18 here, and genotypic susceptibility score that was lower, 0.1 versus 2 for those who were DOT responders. And this is not a durable intervention. So directly observed antiretroviral therapy is already labor intensive, and it appears in this study at least that post-DOT outcomes for these participants with 6 or more months of follow-up was not very different between DOTs and DOT responders and non-DOT responders, either in the proportion of people with HIV RNA of fewer than 40 copies at one or more study time point, or the other assessments here, including CD4 cell increase from screening to 6 months. So it was a rather intensive intervention that did not seem to be durable upon cessation. And these are prior failed strategies for management of patients with multi-drug resistant HIV. Mega Heart, which was a largely French idea, using 6 or more drugs, non-tested combinations, proved to not be better than regular antiretroviral therapy. A double boosted PIs, or 2 protease inhibitors with ritonavir, was also tested with no good outcomes. Hydroxyurea plus or minus mycophenolate raised intracellular concentrations of adenosine and bacavir, but was not proved to be a successful strategy. Treatment interruptions, the purported benefit was the growth of wild-type viruses to quote-unquote resensitize it to available therapies. And again, with the SMART study and others, this proved to be an ill-fated attempt at managing virologically heavily treatment experienced patients. So I will summarize here the DHHS guidelines for selection of new regimen. Perform drug resistance testing while patient is still receiving the failing regimen. And if this timing is not possible, at least soon after, within 4 weeks of therapy discontinuation. Number 2, new regimens should contain 2 or preferably 3 fully active agents. Now, that was not always possible earlier on in earlier time points, but mostly feasible in the latter times. So definition of fully active agents here is uncompromised activity expected per patient's treatment history and results of resistance testing. And so that's what the DHHS guidelines recommend. And again, continuing on the guidelines, drug resistance testing in virologic failure. So the more the patient is known or suspected to have extensive experience with multiple resistance-associated mutations, the more one has to consider phenotypic in addition to genotypic testing. So here, drug resistance is cumulative, so evaluation of drug resistance must consider previous ART history and all previous genotypic or phenotypic resistant test results. Now, archived drug resistance mutations may not be detected by standard drug resistant testing, particularly if that's performed when patient is still not taking the drug in question. So important to note here that drug resistant viruses that are a minority of the circulating viruses, defined here are fewer than 10% or even up to 20% population, likely may not be detected by commercially available assays. That's a cautionary tale. So again, inviting you to review treatment history, even if you did not detect a specific resistance to a drug. Do not discontinue or briefly interrupt therapy in patients with overt or low-level viremia because of risk of rapid HIV RNA increase, CD4 cell count decrease, and clinical progression, all of which occurred in the SMART study that I referred to earlier. So types of drug resistance testing here, genotypic testing preferred over phenotypic testing. For virologic failure, suboptimal response with first-line or second-line antiretroviral therapy if resistance mutation patterns known or not expected to be complex. And so in addition to phenotypic testing, addition of phenotypic testing to genotypic testing is recommended for persons with known or suspected complex drug resistance mutation patterns, like we discussed earlier. So genotypic sequencing assays that analyzes HIV-1 proviral DNA may provide additional information on drug resistance in patients with low-level HIV RNA levels. However, and I would like to emphasize this here, there's significant caution for this proviral DNA measurement because the assays might still miss some or all the previous drug-resistant mutations, and those should be interpreted with caution. In many studies, they have missed sometimes more than half of the the previously identified drug-resistant mutations. So again, genotypic testing, if resistance is expected to not be complex, when it's expected to be complex, addition of phenotypic testing. Third, caution with HIV provider DNA because they may not provide accurate information. So I guess before I turn it over to Dr. Daar, here's a question for him. For which patients do you currently provide this provider DNA genotyping? For the benefit of the 33% of patients who will answer that they will want to use it in this particular patient.
Yeah, so I don't use it very often, but I think we have really good data validating the use of plasma RNA assessments of resistance, genotypic and phenotypic, much less with regards to longitudinal data for proviral DNA. So if I'm going to use it, I'm going to usually use it in a setting in which I can't get the plasma resistance data. So it's going to be in somebody perhaps who has a very low viral load, less than 500 or 1,000, where I'm unable to get plasma genotypic or phenotypic testing done. And then, or occasionally, although I've not done this much, but I know it's been done, where you don't have a lot of information about previous resistance testing, but you suspect based on the treatment history, there may be some underlying resistance. And you're looking to see if you can safely switch somebody who's stably suppressed to an alternative regimen, and you're concerned that there may be underlying resistance. While it's kind of intuitive that may make sense, I think the caveat you presented, that the absence of resistance data doesn't exclude its presence, makes it a little difficult to use it with a lot of enthusiasm in that setting. But I think if it's going to be used, it'll be those low viral load, are undetectable people where you need extra information. How about you, Roger? How are you using it?
Yeah, I would say the same. I think that we all inherit patients who came from another practice, heavily treatment experience, but very little documentation for what they've been on or why they were switched and why they failed. It might be an additional group to consider, but I've used this testing very sparingly because I think that it's not only there are few of those patients, but the data, the justification, I mean, its validity and the accuracy has been less than impressive. And so that's where things stand.
Great, Roger. Thank you so much. That's sort of a wonderful overview of sort of where we are with regards to how common this problem is and how it's emerged. And even more importantly, I think it helps describe what some of the strategies that we're going to use when we do encounter these types of patients. And while we don't see them often, they're in desperate need for, expert management to give them the best chance to get through this. Because if we make mistakes at this stage in their disease when they already have a lot of resistance, we may further limit options for the future. And what we'll do is talk a little bit about how we can incorporate some of the new drugs and previous drugs to attempt to optimize their therapy using the strategies that Roger just summarized. So we have a variety of options for these people, and perhaps the most promising are always new drugs and new classes, where you wouldn't expect any cross-resistance from their previous treatment history. And as it was mentioned, we have ibalizumab and fostemsavir, the two most recently approved drugs. We have enfuvirtide, which has been around for quite a while, which is given as a twice-a-day subcutaneous injection, associated with considerable toxicity, but it is a drug in a distinct class that many people have not been exposed to yet. And then we have the CCR5 antagonist, maraviroc, for people who are eligible. We also know that we have previous drug classes for which we may be able to use newer drugs, or relatively newer drugs, even in those who have underlying resistance. So we'll talk a little bit about the data showing that nukes can continue to have some activity even in people with underlying resistance. There are newer non-nukes, some of them aren't that new anymore, but doravirine and etravirine that have activity in people who have resistance to first-generation non-nukes. We have the PI darunavir, and then we have dolutegravir that works even in some people who have underlying integrase resistance. So let's start with the newest, or one of the newest of the two drugs for this population, and that's ibalizumab. So this is a monoclonal antibody that was approved about 2 years ago, and it actually binds the CD4 cell receptor and prevents a conformational change for the CD4-GP120 complex. So it blocks viral entry, and it was approved based on data I'll show you specifically for those heavily treatment-experienced adults with multi-drug resistant virus. Obviously, not an easy thing to administer because it needs to be infused every 2 weeks, but it is an active drug in people who have resistance to other existing classes. So the registrational trial for this TMB 301, was an interesting phase 3 trial because one of the things you'll notice was that it may be the smallest phase 3 trial you've ever seen, and that had an overall study population of 40 individuals. And I think when the FDA was trying to help provide guidance to these companies that were working on developing these drugs for a select population, they realized that we really needed to use distinct study designs to address the problem. And if you think about the strategy Roger outlined, what we're really trying to determine is whether a drug has intrinsic antiviral activity. And then, of course, if it does, some durability and safety data. So the way they designed the trial was they took a group of people who are highly treatment experienced, multi-drug resistant virus who had limited options. And they monitored them over 7 days, looking at their viral load. And then they gave them a single infusion of ibalizumab, 2,000 milligrams on day 7. And then their primary endpoint was virologic suppression at day 14. So again, adding ibalizumab to their failing regimen to assess the intrinsic potency of the drug, and then give everybody optimized background with the maintenance 800 milligrams IV a day to see if whatever suppression you see is durable, and to assess long-term tolerability. So it was a highly resistant population. Over half had resistance to all drugs from greater than or equal to 3 classes, and 2/3 had INSTI resistance. So these are the results. If you look at the primary endpoint, the proportion who had greater than or equal to a half a log reduction in viral load, it was about 85%. And if you look at the proportion that got to less than 50 at 25, 48, and 96 weeks, you can see that it was on the order of about 50 to 60% achieved this goal. So it really did initially suppress virus as an active agent, and then when combined with optimized background, even in this hard to treat population, achieved viral suppression in about 60%, durable for 2 years. From a safety perspective, it was generally well tolerated. Not surprisingly, adverse events occurred, but there were no people who had significant adverse events that required discontinuation of therapy, and it was mostly generally mild side effects. The other thing they noted is after about 6 months and after 2 years, there was a modest increase in CD4s of about 40 to 45 cells per millimeter cubed. So again, a potential option for this population after its approval. And the DHHS guidelines and the ISUSA guidelines both acknowledge this, and they recommend it for the exact population studied in the phase 3 trial, and the FDA indication for those with ongoing detectable viremia who lack sufficient treatment options to construct that fully suppressive regimen that includes at least 2 and preferably 3 fully active drugs. Now, the newest of the approved drugs is fostemsavir. Fostemsavir is a prodrug of temsavir, and it was just approved in the last couple of months. And it binds GP120 of the virus and prevents a conformational change for it to interact with CD4 and therefore blocks viral attachment and subsequent entry. And it too is approved specifically for those who are heavily treatment experienced with multi-drug resistant virus who need options so that they can construct that perfect regimen Roger talked about with 2 and preferably 3 fully active drugs. Now, the phase 3 registrational trial for fostemsavir was called BRIGHT. This also had a very similar study design. The idea being determine whether it has intrinsic potency and then combine it with optimized background to see about durability and safety. So it had a randomized cohort of people who were highly treatment experienced, but had at least 1 fully active approved agent that was available to ultimately be combined with this. And they randomly assigned them to receive placebo plus their failing regimen or fostemsavir as 600 milligrams twice a day, which is the approved dose, with their failing regimen. And the primary endpoint was to look at viral load reduction over an 8-day course. And you can see there was a significant reduction in viral load of about 0.8 logs in 8 days in the group that received fostemsavir with their failing regimen versus a reduction of only 0.17 in the placebo group. Then they all received optimized background regimen. The other population worth noting is this non-randomized cohort. So these were people who didn't have an additional active drug to ultimately combine. So there were about 99 of them, and they simply received optimized background with open label fostemsavir. And the results were pretty remarkable. If you look here at the 96-week data in the randomized cohort, so these were the group that had another active drug, about 60% at 2 years were virologically suppressed at less than 40 copies per mil. And even in that non-randomized hard-to-treat cohort, it was about 37%. So again, good virologic suppression in the hardest to treat of patient populations, generally well tolerated, mild adverse events, rarely leading to discontinuation of therapy. So again, quite effective as an option for those people. New drug, new class for which you wouldn't expect there to be underlying resistance. The other thing that was really remarkable in the BRIGHT study was the CD4 cell response. This is pretty amazing. If you look at the left-hand panel by cohort, the randomized group had about an average of 200 cell increase over 2 years. And even in the hard-to-treat non-randomized group, it was over 100 cells at 2 years. And that was true in the right-hand panel, regardless of where they started. Whether they started with a CD4 of less than 20 or greater than 200, you see these pretty dramatic increases in CD4 count. So overall, if you look at the BRIGHT study, they found good virologic suppression, about 60%, and these good CD4 responses. So for fostemsavir, again, recently approved for highly treatment-experienced patients, multi-drug resistant virus, and that's how it's currently recommended in the DHHS guidelines based on the FDA indication. What about current options for active drugs in patients with multi-class resistance? We had talked a little bit about existing drugs that might work. This was a really important study in defining how we manage people with treatment experience. This was the EARNEST trial. It took people who were first-line failures on 2 nukes and NNRTIs who had often selected for a lot of resistance to both non-nukes and nukes because they didn't have ongoing viral load measurements. They didn't have real-time resistance testing data. And they randomized them to receive either boosted PI, lopinavir ritonavir, with raltegravir, the boosted PI with 2 nukes, recognizing there was often underlying nuke resistance, or they gave them combination therapy for 6 months and then randomized them to boosted PI alone to see whether a monotherapy alone would be sufficient after 12 weeks of therapy. And you can see here, broken down based on how much nuke resistance they had, that regardless of how much they had, whether they had no active nukes as part of the regimen, or they had 2 to 3 active nukes, the virologic response rate was about 80%. So boosted PI with active nukes or with inactive nukes, just nukes, resulted in similar responses at about 80%. Now, the one group that falls off quickly is the lopinavir ritonavir boosted PI monotherapy. So what this is telling us, because this group did so much more poorly in the study stopped for this group, what it's telling us that even recycled nukes with underlying resistance can contribute partial activity to a regimen. And it wasn't the boosted PI alone doing all the work, because when you gave the boosted PI alone, it actually wasn't terribly effective. So nukes can contribute, but if there's underlying resistance, you can't count it on as a fully active drug, but a partially active drug. This is the key study looking at dolutegravir in people with underlying integrase resistance. This was called the Viking study. They looked at BID dosing based on data that suggested that with underlying resistance, BID was better than QD. And what they found was that overall, the response rates, optimized background with twice-a-day dolutegravir, had pretty good response rates in the 60s. If there was no Q148, it was more like 70 to 80%. If they had the 148 plus one other secondary mutation, it was still about 60% suppression. But when you had the 148 with 2 or more, you had a pretty dramatic drop-off in response rates. So based on this, it's recommended that if somebody has more than 2 mutations with 148, you really can't rely on dolutegravir as being a particularly active drug, but it will be at least partially active in those who have 148 plus 1 or less secondary mutations. So in the right population, dolutegravir twice a day can be extremely helpful. Similarly, darunavir in people with underlying resistance. We give people who are PI naive darunavir once a day. It's very effective. We can overcome mild to moderate levels of resistance with twice a day dosing. And the recommendation is if somebody has one of these darunavir mutations, and obviously you don't have to memorize it, there are many resources you can go to find the information, then you would give darunavir twice a day, and there's good data showing that it provides some additional activity if you give it twice a day. From an NNRTI perspective, doravirine is the newest of the NNRTIs, and while it's primarily been studied in treatment-naive patients and in people switching after they're stably suppressed, we have learned a lot about its resistance data, even though it's never been specifically used in people with underlying nuke resistance. But what we've learned is if you look across these panels, if you look for doravirine-associated mutations, like this 106A being a key one, that you see some increasing darunavir resistance. This is fold change. The green bars represent the doravirine. And here's, again, similar data. If you have these underlying doravirine mutations, you will see doravirine resistance. But if you look at mutations commonly selected for with efavirenz, and again, here now the green bars are in the front, you can see despite having common mutations like 103N and increasing resistance to efavirenz in red, you see no increase in resistance for doravirine. And the same thing is true with rilpivirine. With rilpivirine resistance, you can see increased resistance with commonly used drugs like rilpivirine and efavirenz, but in the green bars in the front, doravirine. So doravirine appears to maintain susceptibility in people who have these common resistance mutations to efavirenz and rilpivirine. So in summary, the target population for people with multi-drug resistant HIV and few treatment options is a small group, but is this huge need. And we're very fortunate that there are companies that are still actively developing new drugs and new classes to help us manage them, two of which have been approved in the last couple of years, ibalizumab and fostemsavir. And then we still have enfuvirtide and perhaps some drugs that may still be active in older classes. And then background regimens, ultimately, when we're trying to construct them, we do it by trying to identify those 2 and preferably 3 fully active drugs that can be part of a regimen with a high likelihood of success.
Great. Thank you very much, Dr. Bedimo and Dr. Daar, and thanks to our listeners for joining in. As a reminder, to view the full educational program, Contemporary Management of HIV, on the Clinical Care Options website, click on the link in the show notes. And please be sure to check back regularly for more episodes on important infectious disease topics. Thanks.